Welcome, everyone, to the first day of this virtual workshop series. I'm Don Berwick. I'm chair of the Committee on Accelerating Progress in Traumatic Brain Injury Research and Care, and I'm very, very pleased to be able to join you and to be joined by my fellow members of this terrific study committee. The committee's been asked by the Department of Defense to examine the landscape of TBI care and research, and to produce a report that identifies major gaps and challenges, highlights opportunities to accelerate progress, and that provides a roadmap for advancing TBI research and clinical care both. Traumatic brain injuries affect so many different communities, and the scope of our work includes TBI in civilian and military settings of all different severities and happening to pediatric, adult, and geriatric communities alike. We'd like to thank the study sponsor for supporting this exciting and very broad task. I feel privileged to be part of it. The workshop sessions that will take place today and March 18th, March 30th, and April 1st provide a very important opportunity for us to gather information and learn from many stakeholders and experts to help us understanding the study, in undertaking the study. The discussion periods during the meeting provide a key chance for the committee to have dialogue with the speakers. Let me also say that written comments and input are also welcomed. You can email those to tbi@nas.edu. Let me turn the microphone over now to Dr. Chanel Matney, who's going to walk us through some of the technical matters in terms of getting your questions and soliciting your input. Chanel?
Hi, thank you so much, Don. We will incorporate questions from the audience viewing the webcast as time allows. You can submit questions using the chat box below the webcast screen that you are currently watching. The committee will receive a record of the questions afterwards, even if they are not addressed during the meeting, but we'll take a subset of those received questions and present them to the moderators for consideration to be answered. In addition to taking audience questions, we will also going to use Slack as a peer-to-peer conversation platform for interested workshop speakers and participants. If you aren't familiar with Slack, it enables you to post and respond to comments and fosters community discussions on TBI needs and opportunities. The TBI Slack is now open and will remain open from today through the end of the final day of the workshop series on April 1st. To join the TBI Slack, go to the invite link that has been posted on the event webpage. Thank you.
Thank you, Dr. Matney. Finally, I want to remind everyone that this session is an open and it's on the record information gathering sessions. You're being recorded. The committee is in the process of assembling information for the study, and members may ask probing questions during this workshop. Those questions may not always reflect their personal views, and we want to emphasize that the committee has made no conclusions or recommendations yet. It would be a mistake for anyone to leave here today thinking otherwise. Let me say a bit more about the study process after this meeting. The committee will deliberate thoroughly before writing its draft report. Once the draft report is written, it will go through a rigorous review by experts who are anonymous to the committee, and then the committee will respond to that review in detail with appropriate revisions that satisfy the Academy's report review committee and the National Academy of Sciences president before it's considered an official Academy's report. At the moment, the committee's report is expected to be publicly released by February 2022. Now it's on to move to this to the sessions in this first of 4 workshops. Today, this workshop, we're focusing on learning about patient and family experiences with TBI to better understand needs and opportunities for improvement. I will then turn the microphone over to Dr. Matthew Fink, a committee member. Dr. Fink is chair of the Department of Neurology, and Louis and Gertrude professor at Weill Cornell Medical College, and neurologist in chief and chief of the Division of Stroke and Critical Care Neurology at New York Presbyterian. Matt, it's in your hands.
Thank you very much, Don. I appreciate the opportunity to welcome our panelists. Before I make some brief introductions of them, let me just tell you a little bit about myself. As you heard, I'm a neurologist, And for over 20 years, my full-time job was overseeing and treating patients in a neurological intensive care unit, where I took care of hundreds of patients who had traumatic brain injuries of various types. So I'm very familiar with those issues. And then I became a patient myself quite unexpectedly. I'm an avid bicyclist, and I was struck by, we think, a truck as I was bicycling. We don't know because the whoever hit me left the scene of the accident. And so I was in that situation of a unknown cause of damage. I was helicoptered to a trauma center, and like others on this panel, probably woke up. I woke up days later in a neuro ICU as a patient, quite shocked and having no memory of anything that happened. So I'm very sympathetic to what all of you are going to talk about, since I went through that experience myself. Okay, but this is really your opportunity to tell us what happened to all of you. And I just want everyone to know who is here as panelists. You're going to get to talk yourselves a little bit, but we have a parent of a teenage boy who was injured. That's Lisa Brandt. It's good to see you. Thank you for joining us, Lisa. Scott Hamilton sustained a severe traumatic brain injury and has spent years developing ways of recovering, and has really had probably has contributed a great deal to this field in terms of treatment. Christine Swift, good to see you, Christine, is a parent, a grandparent, and a former educator, and we're delighted to have her here. Eamon Purser, hello, Eamon. It's good to see you again. Is a veteran of the military, and he sustained a severe traumatic brain injury while on active duty. And then Keith Primo is a retired ice hockey player who sustained multiple concussions while he was playing. In my own practice, I actually saw many hockey players as patients over the years. It's a very high-risk sport when it comes to traumatic brain injury. So I'd like to just pose a couple of things to all of our panelists before we go to you individually. What we want to accomplish with this committee and with the work we're doing is, what do we need to do to improve the care of patients, improve the care of people that have had traumatic brain injuries? So we would like to be able to hear from all of you. What are the gaps? What are the things that did not happen but should have happened from your own experiences? Because that's really how we improve the quality of care. And then I know from personal experience, because you don't really have any memory of what actually happened to you, and those memories never come back. Sometimes it's hard to know how to answer these questions because you may not remember a lot of what happened, and you may have to ask friends and family members to give you some advice about that. So we're going to start now. I'm going to just ask our individual panelists to make some comments about their own experiences, and then we'll go through this. There'll be lots of time for comments and questions from those that are participating in this session. So let's start with Lisa Brandt. Welcome, Lisa. It's nice to see you.
Thank you for having me. Good to see you. So I was asked to share the experience that I had as a caregiver to my son, Max, who was 16 when he received his second concussion playing soccer for his high school team. And one of the reasons I think that Max's story is interesting is because we didn't necessarily experience any of those gaps that I know occur that you were talking about. The call that we had last week where we were talking about really wanting to explore what those gaps were, I tried really hard to think about what they were. So our story is really more about all the things that happened that were great and right, and hopefully being able to look at that to meet the needs of pediatric concussion patients, especially those who identify as athletes who might not return back to their sport and having to rebrand themselves because there's a lot of social and emotional components to that as well. But the first time that I had any experience meeting Dr. Master from CHOP was as an audience member at a presentation she gave that was geared towards athletic directors and athletic parents of athletes. And I remember the takeaway from that presentation that she was incredibly impressive with understanding the needs of this population, that being an athlete is your identity and what happens when you're no longer able to walk onto the field with your teammates, and in conjunction with what happens to them physically when they're recovering. So Max was at the right place at the wrong time, and he was clotheslined on the field, and he definitely does not remember the details of what happened for a huge chunk of time. He thinks that he did lose consciousness. We were lucky enough to be at a school, the Shipley School in Bryn Mawr outside of Philadelphia, that was partnering with CHOP and Dr. Master for some research on pediatric concussions. And so Max had already completed baseline testing as part of the program and was immediately referred to Dr. Master for evaluation. And what transpired after that was just really a very careful, coordinated plan for him. And it was really the first time as a parent or a patient that I've ever experienced a doctor really listening and wanting to collaborate with other fields and making my opinion or the things that I had to bring to the table seem very valid. I immediately asked her about nutrition and the role it plays in the injured brain. And I was really surprised that she felt like that was something that would be great for Max, offered her opinion on what doses so that it was safe for him, and started this really interesting therapy for him based on a comment that I had made about his vision as a young child. And she actually ended up catching some underlying condition that really made his symptoms a lot harder to recover from. I mean, he had nausea and he had ringing in the ears. He did not have taste. He couldn't taste food for a really long time. That was something that you had asked me last week. Headaches and dizziness, cravings for sugar, but it was his eye tracking issues that were really interesting to her. And she sent us to an eye doctor that specializes in vision therapy. And it was discovered that in fact, his eyes were not tracking properly. And that even though he tested well in his vision tests, he really wasn't using them efficiently. And so she really coordinated with months of vision therapy and vestibular therapy, and also coordinated with his school the plan of action for him, which I think a lot of kids don't necessarily get. The school had put together a plan for him and how he was going to be able to return to class and meet his requirements in a way that we're really grateful, because he could not have returned to school. In fact, didn't for about 4 months.
So Lisa, we're going to talk some more about some of these issues, but I want to have all the panelists be able to say a short introduction, and then we're going to come back to some of these things. And I thank you so much for that. Scott Hamilton, there you are. So can we hear a little bit about you?
I'm unmuted.
You're okay now.
Well, thank you, Doctor, and thank you to this committee for what you do generally and what you're trying to do with this committee. What is my story? One morning, 15 years ago, I was in San Francisco on my way to work, going about 40 miles per hour on my Vespa when I skidded on a wet trolley track. And me and my motorcycle and my helmeted head hit the ground, and I skidded about 60 feet. I was Glasgow 3 when I arrived at the hospital with a right frontal contusion, diffuse axonal damage, and what looked like a little nick to my cerebral cortex. The first two doctors my wife met with before she could even see me told her that I had almost no chance of surviving. It was unlikely I would even make it until morning. And given the damage, that should be considered a blessing. 12 days later, I emerged from my coma. Against the odds, I survived. Against steeper odds, from what I understand, about 20 to 1, I can walk, talk, control my anger, think, write. I'm still married to my wife of 23 years, proud father of 2 daughters, one born after my accident, and I am not an alcoholic or a drug addict. So the care I received must have been amazing, right? In many ways it was, but only by hook and crook was it so, often with my wife as the one making that happen. And much that should get some credit for my recovery, I stumbled on myself. Let's keep ugly as a given. I'll quickly summarize the good and the bad in 6 pairs. Number 1, bad, the defeatist attitude. Those first 2 doctors that came in, met with my wife, said I was toast. Now, good part is that the third doctor, the lone good doctor here, said my chances were bad, about 1 in 10, that I'd even come out of my coma. And chances were worse that coming out of the coma would be a good idea. But he said it was worth a fight, and he knew what to do, and he knew what not to do. He was not anxious to give me a craniotomy, for instance. Good thing number 2, I'll say, is music. When I was comatose, my wife knew that being there every night and singing 2 songs to me that she knew I loved might help bring me back. It's bad to me that music is too absent in ICU coma treatment and in rehab, despite Oliver Sacks and lots of good research that suggests it could be a huge help for those in a coma and in the months of recovery for those of us who had TBI. Good thing number 3, acute rehab. Recommendation my wife received from several neurosurgeons was how critical good acute rehab is in the first months following release from the hospital. And after a big fight with my insurance company, I got it. For me, the bad part of that is the struggle to get something other than bed rest in a nursing home for my recovery. It was a huge struggle, and how rare good rehab is for many TBI victims. If I'd been sent to a nursing home for bed rest, I wouldn't be talking right now. Bad thing number 4, there was no guidance for follow-up post-rehab. Even when I got to a good rehab program in Santa Clara in the Northern California, when I graduated, there was no guidance on the best recovery process going forward, what would be good to do and what I shouldn't be doing. And then I ended up with a very substandard outpatient rehab program. But I was really thrilled, should be thrilled, certainly in hindsight, that I ended up at a very good rehab center for acute rehab. A good thing, number 5, is the follow-up and ongoing care I had from my trauma doctor, Jeff Manley, was a huge help. Medicine for seizures, medicine for anger, medicine for sleeplessness, referral to an endocrinologist for various complications, and later to a psychiatrist. Key stuff in my recovery that I was lucky enough to get from my trauma doctor, who was just good enough on his own accord to call and check in or take my call, sometimes when he was even in surgery. Bad is that no doctor was officially on my case post-acute rehab. Nobody recommended the use of brain fitness technology like Brain HQ. No recommendation about nutrition, no recommendations about exercise or anything for brain health. Crazy. that I was just excused from rehab and given nothing.
So,
Uh,
Scott, we're gonna have more. We're gonna talk about this more.
I'll conclude
Okay,
with
Ed,
one
I'm
last
just
thing.
trying. Yeah, I'm being mindful of the clock.
I
So
understand.
everybody gets it.
Bad is that a psychiatrist should not be optional. As many years after my accident, I began working with a psychiatrist, but it's just bad that that was not automatic. Good that I have a great psychiatrist and good medication on an ongoing basis and good brain fitness habits.
Okay.
More to come.
More to come for sure. All right, Eamon Purser, we'd love to hear from you.
Oh, good morning. How's everybody doing today? So my name is Eamon Purser. I was in the military. My accident is a little bit different from everybody else's in several ways. So basically, I was on a mission, our training mission. We were airborne, jumping out of airplanes. The guy in front of me did not want to go. And I ended up going out wrong. And I was knocked up against the side of the airplane for several minutes until they realized I was still out there. My parachute finally opened. They helped me open it. I fell completely to the ground with my parachute open, but I wasn't able to get my parachute and direct it in any certain way or help myself to the ground. So when I hit the ground, I shattered my leg, bones sticking out, everything was kind of crazy. So immediately they started treating me with that. And even after that, it was all treated for my leg injury. It was never come up if I had any issues with traumatic brain injury or anything for concussions. And still to this day, it's, kind of curious to me why I was never treated for anything like that. I didn't get any symptoms, and all of that other stuff didn't come till much, much later because there was so much pain with my leg and everything else. And there were so many issues at the time that were just going in different directions. The headaches and all of this stuff obviously came from my leg injury. Nothing was ever brought up about anything else. So treatment was none, to be honest with you. And I didn't get treatment until much, much later when I kept complaining and saying, hey, look, the headaches are still coming. I don't have any recollection of a portion of my life was kind of missing. And it wasn't till much, much later when I was just absolutely had nowhere to go and didn't know what to do to figure out what was wrong with me. I still had no clue that it was from concussions or anything like that, but it took a lot of reading up and doing all that stuff to figure out that I had bigger issues than what was just considered nothing wrong with me, is what the military kept telling me. And that just kept going and going until finally one day, which the biggest thing in my treatment was talking, and I had no clue, because had it not been for me telling my story, finally getting to the point where I could tell my story, I got to the point where somebody listened, and they were working. I was in Maryland at the time, and they said, hey, we have a study that's going on in Pittsburgh, and you should probably sign up and see what happens. And I finally did, and it worked. Some things finally came to fruition. Things started making sense, and that's it. We'll leave it at that for a moment, and then keep going from there, because I keep talking about this all day. So
Thank you, Eamon. No, we're going to be talking about it some more a little bit later, but thank you very much for sharing that. These are really quite amazing stories that people have to talk about. I'm glad we were able to discuss it here. Christine Swift. Hello, Christine. So nice to see you today. So tell us a little bit about yourself. You're unmuted. Unmute. There you go.
Can you hear me now?
Yes, we can.
Okay, thank you, and hello, and I'm very happy to be here. I received a traumatic brain injury 5 years ago. I was working in Philadelphia, crossing the street, walking with the walk light and in the crosswalk, and a car hit me and ran over me. The man driving the car was looking down at his computer and obviously didn't see me. And I was non-responsive, and they thought I was going to die. They told the man who hit me, and the police, writing up the report, wrote it up as if I were dying or going to die. However, thank goodness I was 2 blocks from the hospital where they do brain surgery. They took me there, and within 30 minutes, I was having part of my skull removed. The left side of my head was damaged. And I also had, my left leg was broken in 4 places, and again, bones sticking out. But I lived, and they had to remove part of my skull. I have no memory of the accident or the first 4 weeks in the hospital there. They then moved me to a rehabilitation hospital, and I start having memories of that. Although I have to say at the time, I didn't realize it was a rehabilitation hospital. They kept telling me things, and that's the reason I knew some things. First and foremost, the reason I was there, they kept telling me every day that I had been in an accident and I was hit by a car and run over. I had excellent care. I was very, very lucky. The surgeon who operated on me and that hospital, according to my husband and family, say things were excellent, and at the rehabilitation hospital. I then was moved back to Wisconsin, where I live, and did some doctoring in Madison, and I had excellent help there with doctors, including Mike McRae. And I think the things that were negative about my care, first and foremost, I want to say the most positive thing for me was the love and help and support of my family, my husband, my sister. My husband and sister were in Philadelphia for the whole 2 months I was there, and they took shifts. So someone was with me all the time, either talking to me or taking me for walks and whatever. And that was very impactful for me. The negative things were, I had no ability to self-assess. I also didn't have taste, and my taste changed dramatically. No stamina, and I still have stamina problems as the day wears on. I say my brain gets tired in the afternoon and evenings. I sleep a lot more than I used to. Noise. In the first few years, I could not hardly stand any noise. It felt like everyone in the room was talking to me, and I knew they weren't, but I still have some of that, but it's gotten a lot better. I cannot multitask anymore, which I'm told I was pretty good at before. And one of the negative things for us was that my husband and family, I feel, did not get enough information about my recovery. And perhaps the doctors didn't know it. I don't know. But, my husband, God bless him, practical things like, when could I actually drive again? I mean, how do you know when you're to the point when, you recovered sufficiently to be able to drive, or to spend money, even just, go shopping, albeit with someone.
Okay.
So I think more care, more information for the caregivers is our biggest negative.
Thank you. Thank you so much. And we are delighted that you made such a great recovery. I think a number of us on this call had that experience of being told you're not going to make it. My own experience was when my wife showed up at the emergency department of the trauma center where I had been helicoptered to. The first question that she was asked was, did your husband sign an organ donor card? That was the very first question, as if that was it. And so many of us have had these similar experiences of people sort of giving up right from the beginning. So I hope that's got to change as well. So we'd love to hear from Keith Primo. Thank you for joining us, Keith. Great fan of hockey. In spite of all the injuries, we just want to make it safer.
Yeah, occupational hazard, I suppose.
Yes, indeed.
But good afternoon and good morning to those in a different time zone. First, I just want to start by thanking the other panelists for speaking out. I know how challenging it is at times, and although you all look wonderful physically, I know the emotional and mental challenges that it poses. It's not visible, but it's there and it's real. So thank you for taking the time. My case history is a little bit different than the other panelists. Maybe a little bit more similar to Lisa's son, in the sense that mine was cumulative. I had what you would call 4 documented concussions, but documented concussions doesn't tell the whole story for me. My first documented concussion was in 1997. But I've been playing hockey, organized hockey, from the time I was 5 years old. So I'd been getting bumped on the head from the time I was from about 1976 to 1997 when I had my first documented concussion. I'm often asked if I could pinpoint how many concussions I had over my lifespan, and I can't. And my answer typically is north of 10. As I said, my history is a little bit different. The first documented concussion back in 1997 was a neutral zone hit, blunt force trauma to the head. Didn't think it was that severe of a hit, but again, I believe that I was coming off a previous hit, maybe a month or two earlier, and not understanding the dynamic at the time. But I spent the night in a Hartford hospital. And at that point, I was told that I was off of activity for 1 full week. I wasn't allowed to go on the ice. I wasn't allowed to practice. Wasn't allowed to play. And I thought, wow, how wonderful, how conventional that they're taking my health very seriously. Only to realize that it's not a light switch, and that after a week I wasn't fully healed. And then that led to my second concussion was in 2000, where again a neutral zone hit. A defenseman stepped up on me, and I turned and he caught me. And at that one, I believe I was out, because all I remember is the trainer being over top of me. Again, a hospital stay in Pittsburgh, and the next day we were in the playoffs. So the next day, I in order to be cleared to play the next night, I had to go see the neurologist and do my impact baseline test. At that time, we were doing impact baseline tests as the only real pre-assessment for concussion. And I remember, and so we had all kind of trained ourselves to manipulate the test so that we could pass. And I remember going into the office, doing the test, passing the test, and the neurologist sitting across from me and saying, "Keith, I know what you're doing. You've passed your baseline. There's nothing I can do from keeping you from play, but just please be careful." And I kind of giggled and laughed. And as I walked out of her office and onto the street in downtown Philadelphia, I remember having the worst headache of my life. I strained so hard to prepare myself for that test that I'd given myself a headache. I was cleared to play. I went on to play the next night and finish the playoffs, only to have 2 more concussions follow. One in 2004, which kept me out now for 6 weeks. And then my fourth documented concussion in 2005, which I never returned from to play. I was forced to retire, and it led me to have symptoms for 7 years. 7 years of concussion symptoms before I was able to return to some semblance of normalcy, what I would call my normalcy. And again, different in some cases. I was afforded the opportunity to see as many specialists and therapists and doctors and conventional, non-conventional, Eastern medicine, Western medicine doctors that I wanted to see, and some with varying degrees of success. But the one thing as my time runs out is that I'd like to say was that with each of those therapies, of all the therapies and medicines that I was afforded the opportunity, I never had any follow-up to this day. And that was probably the biggest gap for me, was that I wasn't given the opportunity. I don't have follow-up. I go to see the doctor once a year for my annual checkup, but I don't get the opportunity to really be diagnosed or re-diagnosed.
Okay, thank you. Thank you, Keith. I would say there's a theme from everything I've heard from all of you, is the issue about follow-up after the initial injury and recovery from the initial injuries. So I'm going to pose some questions to all of you. And I would just ask you just hold up your hand like this, and then I can call on you individually to hear what your thoughts are. So the first is, if there was one thing that you could change in the course of your care, and for Lisa, for your son's care, if there's one thing you could change to make it better, what would that one thing be? And there are probably more than one thing, but let's start with that. Go ahead, Keith. Keith, I saw your hand up first.
I'm going to share two. I shared the one, which was the follow-up, and the second thing for me would be the collaboration. I felt during the course of my treatments that there was a lack of willingness to work together across processes that would allow me to benefit the most, because I felt at times they were protecting what they felt, because it was, concussion in the last 20 years has become very mainstream, and they felt that what they were doing, or their treatment and their processes, were better than someone else's, and they weren't really thinking of me as the individual or the patient.
Okay, Scott, I saw your hand was up same time. You're muted. You're muted. Unmute.
I think the one thing I would change, if I had to be limited to one, is the attitude, the defeatism that seems to be so common in this realm. The number of us who are going to die, the extreme limits on what progress you can make in rehab. It's as if there's a whole industry of TBI treatment that hasn't heard of neuroplasticity. They don't know what's possible. And that's the one thing I would change.
Okay. Eamon?
Yeah, I would like to say, just listening. I feel like it's just not a big thing these days, especially with the military and then transferring into the civilian world. I can't tell you how many times I would go and say, hey, it was clear, memory issues, headaches, migraines. I couldn't even do stuff most days. Over and over, the things that were wrong, and nobody listened. Everybody kept saying, it's because of this and because of that. I actually had one doctor tell me that my memory issues is because I took Sudafed. And it was, after I explained the situation and what happened with me, it was still put to the wayside that there was nothing wrong. And I think listening could have been probably one of the biggest things, because that would have sparked someone to say, hey, this, let's try something different. I'm not looking for an end all be all. I'm looking for just some sort of comfort for everyday life.
Yes. Lisa, go ahead. And then Lisa, and then afterwards, Christine.
I would just like to echo Keith's comments about collaboration and partnership. And, you know, we had a doctor prior to visiting with Dr. Master who didn't want to collaborate and listen to some of the issues. And so when we got to Dr. Master and were in her care, she picked up on maybe the reason he was struggling so much is that there was an underlying condition that was exacerbated by the concussion. And so, you know, I think that there has to be some kind of advocacy for yourself, which can be a very difficult thing when you are expressing concerns to a so-called expert that might not be willing to look outside of the box. So, you know, I had known or had felt that there were issues with his vision that hadn't been detected. And I kind of, thinking back, wish that I had pressed that a little harder at the time, but it eventually was resolved. So
How old is your son now? How old is he now?
he's 19, almost 19.
Can I ask how he's doing?
Thank you.
Yeah.
He's great. And he
That's good.
transitioned his love of sports into a different realm. And now he's a manager of the SMU basketball team.
Terrific. That's great. Okay. Christine, you were going to comment.
Yes. The one thing I would try to change is to give people more information. I think from this panel, sounds like I'm one of the rare ones who had excellent care from doctors and healthcare personnel. But for my husband and people who were taking care of me once I got home, which was 24/7, people do not know what a traumatic brain injury is, what it does, and how to care for people who have those.
Thank you. I'm going to add two comments based on what all of you have said and from my own experience that there are two huge problems that affected everyone here. The first is lack of follow-up. I was discharged from a neurological intensive care unit directly from the ICU to home with no follow-up, zero follow-up. Just had to hunt down all the various other doctors I needed to see to take care of my problems. And I was a doctor, so still am, but it's sort of shocking when you think about it. And the other is that every person with a traumatic brain injury develops a memory impairment to some degree. It could be mild, it could be severe, but every single person does. And that makes it almost impossible to advocate for yourself. So you need another person to advocate on your behalf, whether it's a family member, a friend, and unfortunately, some people don't have those advocates. So they really suffer. So those are two huge areas that all of you have expressed in one way or another. We need to have advocates for us if we're going to get through this type of thing. So, all right, we're going to open this up to other members of the committee who have some questions for all of you. And let me see if we see any hands up here. We have a question from Dr. Berwick. So let me just I'll speak. Or Don, why don't you just go ahead and ask your question?
Yes, thank you so much, Matt, and thank you, panelists. That was really compelling. Please keep speaking up. Several of you mentioned barriers in collaboration. I'm curious to know, are you commenting more on collaboration between the clinicians and you, the patients and families? Or are you commenting on teamwork and collaboration among specialists? Any of you that have stories about that would be very welcome.
Yep, Keith, go ahead.
So sure. So in my case, that's actually a good question. It was both. It was the collaboration amongst those who were overseeing my treatment as much as the other, but I felt it fell short in both regards.
Mm.
Anyone else want to comment about that, the collaboration issues? Lisa, oh yeah, Christine, go ahead.
I have one sassy comment, and that is send the people to Wisconsin. The care I had here, fabulous. Even now, I know there are at least 3 doctors I can call right now who will take my call and still hear. And I do not call them. It's not like I bother them all the time. But
It's nice to know that they're there.
yes.
Yes, yes, for sure. Susan Margulies had a question.
Since follow-up seems to be an important echo from all of you, I was wondering if, and perhaps Christy, you could go last, for those of you who feel you haven't had good follow-up or have experienced it fitfully, what does good follow-up mean to you? If you could describe what good follow-up is, what would that be? And then if Christy went last, you can add anything that isn't mentioned. Thank you.
Go ahead, Keith, go ahead.
Sure. So as I said, the only real follow-up I get now is an annual checkup with the team doctor. But I would do that under normal circumstances. And as an example, the last 12 months, I noticed, getting out of the shower and drying off my leg, I was starting to lose my balance, or bending over to tie up my shoe, I was losing my balance. And I wouldn't, under normal conditions, I wouldn't really put much stock into it, but I felt as though this was something that wasn't normal for me. And so I recently started under the care of Dr. Chad Pressmack out in Denver, neurosurgeon for the Denver Broncos. And after evaluation, I discovered that my vestibular system is way out of whack, and I've begun to retrain my vestibular system from a balance and a vision perspective. And so for me, I did vestibular therapy. That was the biggest underlying issue I had with my last concussion. And after I got to a certain point, it was, you're doing better, you should be okay, on your way. And I felt as though somehow there should have been a constant communication with me, either through my personal doctor or through them, as a follow-up. And I don't know if that's an infinite period of time, because now that we're talking about 15 years ago since my last concussion, but I was forewarned that at some point these type of things could present themselves. So I felt as though any type of follow through probably would have helped me recognize this and not been at my own accord.
Yes, Scott. Turn on your mic. You're
For me, when my neurotrauma doctor was the guy who would call and just say, "Hey, how's it going? Just want to check in." And I could say, "Oh, I'm doing okay, but I feel so bad because I'm sleeping all the time." And for him to say, "Okay, sleep is what you should be doing." Or when I would be able to call him and say, "I'm having a real issue with this," and he would give me medication or a referral. That everyone who has a severe TBI should have some doctor assigned who calls them and who they can call with questions, issues, I think. That's follow-up.
Anyone else?
Yeah, I mean, I'll say something real quick if that's okay.
Sure, sure.
I feel like everything that these past 2 gentlemen are saying is absolutely true. I've had 0 follow-up. And if it wasn't for the traumatic brain injury study that I did in Pittsburgh, God bless those people, man, because I don't know where I would be without that. I've had 0 follow-up from anybody in the military or civilian. Anytime I go to the doctor, it's the same underlying issues. And, like the first gentleman had said, loss of balance and stuff like that. Yeah. I mean, I have to laugh now these days because it's like, oh, I've got something else wrong with me, and then I go to the doctor and talk to them about it. And it's like, it never comes up about, the TBI or anything of the concussions. I mean, I bet I had more than one concussion on that accident. And then maybe several more with the military. And it's never been brought up. I've never gotten a phone call about anything, or the follow-up study, or should be a study in itself, just because, we don't know what's happening to us on a daily basis. So I mean, a follow-up would be fantastic in some sort of sense, and it would make us feel better too, to be honest with you.
Thank you, Eamon. Thank you. Eric, oh, yes, Christy.
When you first asked the question, I wrote down here, people who care, exclamation point, including doctors. And yes, I've been very fortunate that in my follow-up, I have doctors who care. And I agree wholeheartedly with what Scott said about a doctor calling you and seeing how you are. And I know it's beyond personal for us, of course, but I think for medical people, perhaps this is what they do all the time. So I can see how it doesn't become quite so personal for them. And it would be hard for them to continue to care about us once we're released. But that is what we need.
Okay, another question, Eric Schumacher, yes?
Yeah, thanks very much, Matt.
Just introduce yourself to the group so they know who you are. That's just real quickly. You're back, yeah.
Sure. My name is Eric Schumacher. I'm a physician by training, and like Eamon, I'm a former military member. In fact, truth in lending, I was the Surgeon General of the Army when Eamon was injured out in Washington State with the Special Operations Group. I'd like to return back to the initial evaluation that you received, Eamon. We had a little exchange on chat, and I learned that he was with a Special Operations unit and was injured out in Washington State in 2009. And I just want to know about whether you were aware, Eamon, whether you received a formal TBI evaluation, even despite the fact that you had severe appendicular injuries. You received no screening test for TBI. And just for everybody's knowledge, I mean, it's a bit unnerving that we were doing a better job in battlefield medicine around TBI at that time than we were back in our fixed facilities back at home. So that a TBI of that magnitude would have been recognized and treated probably better in Afghanistan than we could treat it. We did treat it at Madigan. And finally, just real quickly, Eamon, are you receiving any follow-up at all through the Veterans Administration?
Nope, not at all.
Have you sought it?
It's over and over and over and over again. I honestly, every time, like I said, I'm constantly told there's nothing wrong with me. And my situation is a very unique one. I mean, I had a shattered leg. There were bones sticking out. Like, their main concern at the time was, getting my leg back to normal, which I'm very, very thankful for, because those doctors over in Washington were fantastic in that aspect. Wow. I've run a marathon. I've done everything that people said I couldn't do. But from my knowledge, I had zero anything to deal with TBI or anything. And like I said, it wasn't, if it wasn't for the people at the University of Pittsburgh, I wouldn't be where I'm at today with the knowledge that I have and everything that I have. And it's just talking about things that happened to me. And that's very difficult to do sometimes.
Yeah, and jumping out into an airstream at 140 miles an hour for a C-130. I mean, Tom Cruise appears to be able to do that in 007, but the average person can't be slammed up against the side of an airplane without getting a lot of head and other injuries. Well, thanks very much, Eamon. Thanks for what you've done.
Absolutely. Thanks for the question.
Thank you. Okay, we have a question from Helene Moriarty. Would you like to go ahead?
Yes.
Where are you, Helene?
I'm here.
Okay, go ahead.
Actually, Eric, asked my questions to Eamon, but Eamon, do you have any ideas on how the VA could have reached out to you to offer services when you said that we're not receiving services now? Any ideas about that?
Yeah, that's a good question. So I was with USASOC, Special Forces. So I was not aware of it until after I got out of the hospital and stuff. But I was assigned a person that was with me, to this day, with the Special Forces community. And they there for a while checked up on me, made sure everything was okay. That was how I started getting help, was saying, hey, I'm having issues with this. And they're like, okay, cool. Let me go contact this person. But that slowly faded. I haven't heard anything or seen anything from anybody in years. But that could have been the way, it was all about my leg, always all about my leg, and for good reason, obviously. But anytime I complained about other stuff, it was like, okay, let's go give you to somebody else. And then I was always passed around. And I felt like that was the biggest issue, is always being passed to the next person, and no one took time to actually figure out what was wrong with me. But yeah, I feel like that could have been a way. But again, I was never treated for TBI when that happened, or anything of that matter. So you're right. There wasn't anybody that really knew about it at the time. But as I kept bringing it up, it never got put on my record or anything, because they didn't want to treat me for something else, or pay me for it in that mind frame. But
thank you for your ideas around that. Thank you.
Yes, ma'am.
Thank you. Question from Corinne Pigesa.
Yes, thank you. So our charge is to lay a foundation for future research. So I'm curious if in any of your experiences there was a time when the answer from the doctors is we just don't know, or if there are things that you wish the science had been more advanced to help you in your treatment and recovery.
This is for all of the panelists, correct? Yes, for all. If anyone has a comment about that, please jump in. Christy, yes.
I do not have anything specific, but I just ask everyone, or why isn't there more information out there on traumatic brain injuries? You never hear about it. I don't think I'm the only one who have hardly ever heard about a traumatic brain injury until I was involved in it. Where is the information? Why hasn't there been more research done on traumatic brain injuries?
It's a very good question. That's one of the reasons we're here, to try to answer that question for you and for others. Part of it is a lack of advocacy on the part of people that have suffered traumatic brain injury. I've been shocked by how little advocacy there is. And so that's something we're going to need to address as well. So, Monica, you wanted to ask a question? You're
yes,
muted.
thank you so much for coming and sharing your stories with us. You importantly mentioned the need for follow-up, and I was wondering if you could comment on whether, as past patients, where would you like that follow-up to occur? Would you prefer that to occur closer to your home, back at the trauma center? And is there a doctor type who should provide that follow-up? Should that be one of the specialists, or should that be a primary care provider? Thank you very much.
Yes, Scott.
It was great for me to have somebody who actually knew something about the brain and about traumatic brain injury. And it doesn't need to be in person. A phone call, as we're learning with the pandemic, Zoom works just fine. But I think somebody who cares about you and who knows something about the brain is what I would recommend.
I'll make a comment about the primary care physician having experience, again, personal experience. Primary care physicians are afraid to get involved. They just don't know enough about this. They're going to just immediately send you off to 18 different specialists, and most of those may not even be appropriate. So it does have to be someone who has the correct knowledge and cares. Those are the two criteria: knowledge and caring. And that's what you need. Don Berwick had a question. Don, you want to ask it, or I can ask for you? You want to?
Yeah, thank you, Matt. I'd like to know about insurance coverage gaps. Did any of you incur a large medical or health bills that were not covered? And if you're willing to say, without violating your privacy, what those areas were, that would be very helpful. Thank you.
Yes, Christy.
I might have a different situation, but my husband and I sued the man who hit me, and we won that lawsuit. And when we won that lawsuit, we had to pay all of my medical expenses, which was over $1 million. And today, when I have treatment, if it's related to that accident, we still have to pay for that treatment. Now, thank goodness doctors are very smart. And so a lot of times my doctors don't even mention the brain injury, so that my insurance now will cover whatever need I have.
Anyone? Yes, go ahead, Lisa, and then Scott. Go ahead.
I would say that the insurance covered the vestibular therapy, but it did not cover the vision therapy. And I had tried several times to resubmit. I think we did get a little bit back from that, but I don't think that there was buy-in from the insurance company that was something that Max needed.
Scott?
I just wanted to reiterate my experience of having to really fight Blue Shield of California with a threat to publicize some of what they were doing with the guy who used to work in the Clinton White House until they would pay for acute rehab.
Wow.
It was going to put me in a nursing home because it's a lot cheaper. And it's just, to me, it's just criminal that so many victims of TBI are just forced by insurance companies into bed rest, which is just killing their chances of a good recovery.
Yeah, I'll comment again, having taken care of a lot of patients like this in my own experience. In New York State, there's a no-fault insurance that goes into effect if anything is related to an automobile accident. If you're hit by a car, it automatically goes into no fault. And that's a problem for the patient, because most doctors in New York State don't accept no fault, so it limits the care you can get to a group of doctors who accept it, who, let's say, may not be the greatest doctors in the world, who accept this. And then at the same time, the no fault wants there to be a lawsuit because they want to recoup the money that they have to spend through a lawsuit. So it forces the patient and the family to get into litigation that they may not even want to get into. It varies from state to state. I don't know what it is in other states, but the New York system is an awful, terrible system for people that have suffered injuries as a result of automobile accidents, for sure. Bad system. Wow. Any other questions? Eric, you have another question? Or you just didn't turn off your blue hand?
No, I turned it off. But thanks. Because I think this is related in a sense to the insurance coverage that Don is. In this arcane world of the DOD and the VA, I don't want Eamon's comment to be overlooked. The military pays for injuries and illnesses, or illnesses that are incurred during military service, especially that most disabling injury or illness or combat wound that renders them unsuitable to serve longer. Once they transition to the VA absorbs the cost of that. Both agencies do their best to try to identify injuries or illnesses that should be addressed. But the perception, I think, often by the patient is that both agencies are struggling not to have to assume responsibility or cost for that. And this goes back a very long time. It was a part of congressional hearings back in 2007 when the Washington Post had a series of issues around Walter Reed and other care. And it continues to be a problem that, at least for the military, which like Keith's population represents a high-risk population for TBI, continues to plague them. And I think in some way ought to be acknowledged in the study. So, thanks very much.
Thank you. I have a question for all of the panelists. Did any of you participate, or did family members participate in any type of support groups? Did anybody find that have that experience? No support groups, which I find quite shocking, because in neurological diseases, we have support groups for every neurological disorder you can think of. And why would there not be support groups for people that have had traumatic brain injury? It's kind of shocking. Yeah, Eamon.
Not only was there no support groups, but it got to a point where it finally came to me that I had to be completely open with, my daughter at the time, who was really young. I had to explain to her why, I would keep forgetting things, and work issues and stuff like that that kept coming up. There was no support on that aspect to where I could comfortably tell people what was wrong with me, or say, hey, if I can get you to listen to this real quick, or this support group or whatever. Especially with my family issues with keeping a relationship at the time too was very difficult, because there was always something wrong with me. But yeah, I mean, I feel like that would be something that would be just awesome. I mean, even if it was something, my son has autism, and I didn't understand what autism was when he first came about, but it was watching videos and constantly figuring out what was wrong and educating, which is what brought me to where I am today. So, I mean, education. 100%. That would make a lot of sense.
Yeah, that's what support groups do. That's a big part of what they do. Does anyone else want to make any comments about that? Christina, yes. Christina.
I was going to say, go ahead, Scott. I think you were going to say something about this topic. I had a question.
Just quickly on this, I think I found with TBI that there's a million different types of TBI, and that maybe the caregiver, doctors and rehab people and everyone, just every TBI is different. But in my experience, just my research, they're not that different. They're important differences, but boy, there are a lot of commonalities, which is why there ought to be post-rehab literature you're given on here. Here's what you need as a baseline for the rest of your recovery. But establishing that commonality, I think, would help with the support groups and more.
Okay. Any other comments? Christina, you wanted to ask a question or a comment?
I did, if that's okay.
Sure, absolutely.
I'm a pediatric sports medicine specialist, and so I have one particular perspective on this, but I really would love to hear your thoughts specifically. My particular interest is in concussion, which is a mild form of traumatic brain injury, but we do see a lot of kids who have more what feels like moderate, in terms of outcome. And we're always trying to balance that whole aspect of making sure that we maintain hope and optimism about neuroplasticity and resilience, and the fact that you can recover from these injuries, while at the same time recognizing and acknowledging that there are serious, implications, either short, medium, or even longer term, that kids, young adults can struggle with for a while. And so, I think I really take to heart what you all are sharing about how important it is for physicians to listen to their patients. But can you give us specific advice about how we can balance that, hope and optimism with also, being concerned with the fact that there can be, serious issues that we have to deal with? And how would you, advise us in terms of how best to approach that with you all, with patients and families, in order to try and maintain what seems to be almost like conflicting messages, right? We're optimistic and we're hopeful, but this is a serious injury that can have a big impact. And so how do we do that adequately for you so that you don't lose hope, but that you also do take it seriously? Because I do think that you've seen in the medical field how you can have physicians who kind of go one direction or the other, and maybe they're misdirected, that they're trying to be so overly optimistic that they tell you that you have no problems. And then you have other people who are like, this is so terrible, that then you have no hope. And so how do you balance the two? Because I feel like we have both. We are concerned and we want to take concussion seriously in kids, and we do need to take traumatic brain injury seriously, but we also have hope. And so how would you best advise us to do that?
Any takers to that question? Yes, Scott?
I think my first recommendation is let's err on the side of optimism. Again, this realm seems to me to be so dominated by defeatism. This is a terrible injury. This is awful. You're stuck with this forever. But let's focus on neuroplasticity. Let's have that hope. Let's err on that side, because we've got a long way to go to correct for all the negative, the defeatist. It's patient optimism too, because as we've heard with all of us here, it's a long road. This isn't an overnight thing. It's a long road. But err on the side of optimism.
Okay. Keith, yes.
So I've spent a lot of time, counseling, other former players and people with, suffering through post-concussion. And my message always to them is, reach for your normalcy. And that was that for me, that's the strongest message. That's what drove me. Was I knew what normal felt like. I knew what I felt like before my concussions. I didn't know if I was ever going to get there, but I was never going to give up hope. And so I think that kind of answers your question in both sides. Like, you guys have to be the driving force to help us get back to that normalcy, but the message has to continually be, search for your normalcy, fight for your normalcy, get to your normalcy, because you can get there. And I don't know how long it's going to take. Could take a really, really long time. But try and get back to your normalcy.
Well, thank you so much for that. Lisa.
I was just going to add that, when we don't know the answers to things, it can be really anxiety producing to receive that message. So I would just say that for practitioners to listen and validate what their patients are saying, and be empathetic. And I think that, when you're not feeling well, you need somebody to understand that your symptoms are real and support you, and that, it's not necessarily bad to hear we don't know. And to be given, I heard a lot of times, I hear this a lot with my patients. That was very comforting for Max and for me. And, hearing I don't know isn't always scary if it's presented right.
Yes, indeed. We wanted to try to leave a couple of minutes if there are questions that came in from other listeners, participants who logged in. Katie, have you been checking on those for any questions?
Yep, we've had a few questions, and I guess I'll just pose one in the couple of minutes we had remaining, which was a question about, for our panelists, what type of therapy they have found most helpful to their recovery, if they have any particular thoughts on that.
I heard Brain HQ mentioned a couple times. So
Brain HQ for me, and exercise and good nutrition for the brain.
Yeah.
I had two specific that were non-conventional for me. One was prolotherapy treatment.
Can you describe what that is?
Sure. So prolotherapy is a concoction of lidocaine and dextrose injections that were placed in my cervical and thoracic and lumbar spine. I had a lot of elasticity in in the ligaments in my neck from playing and the trauma and my injuries. It's used to strengthen those areas. It sends the inflammation into those areas to produce regeneration. And the second one was neurofeedback, which is like a neural brain mapping that they use for, I believe, for kids with autism and things like that. But I had tremendous success with that as well.
Any other comments about particularly beneficial therapies? Kate, Christy, yes.
The two that I have weren't therapies from other people, but eating healthfully and exercising. I know that these are important for everyone's health, but they have become even more important for me since the brain injury. And the mental aspect of the help of those things has been phenomenal.
So I'll just make a statement about it. You'll all agree with this. The key is to never give up and to keep working to get better. What Keith said is true. It can take a really long time to recover from some of these injuries, but there is brain plasticity. Sometimes it is slow. And the older you are, the slower it is. Young people have a great deal of brain plasticity and they can recover more quickly, but you just have to keep at it. You don't quit, you don't give up, you just have to keep working at it all the time. So I want to thank all of you for just a terrific session. You were all just really helpful, and we thank you tremendously from the committee and from myself personally. You were wonderful. Terrific group.
Thank you.
Thank you.
We're going to move on to the next session, which is disparities in TBI outcomes. The session moderator for that is Corinne Peak-Asa, who's on the Zoom. So I will turn it over to you. And thank you all again.